Thank you all so much for taking the time to tune into tonight's Next Generation Editors Journal Club. My name is Ryan Austin, a plastic surgeon in Toronto, Canada, and I'm the lead of the Next Generation Editor session here at ASJ. And tonight we're going to be reviewing an article from the November 2023 issue of ASJ entitled Wound Healing Complications with Tranexamic Acid, Not the Silver Bullet After All, and the accompanying article to this month's feature. Tonight is actually a very special journal club for us here in the NGE team because for the first time in ASJ history, we're actually going to be offering a live audio translation stream of the session in Portuguese. Dr. Diego Pereira, who's our fellow here in Toronto, has kindly offered to translate tonight's session. So if you want to listen in English, you don't actually need to do anything. But if you'd like to listen in Portuguese, you simply need to go to the Interpretation tab in the Zoom toolbar and select the Portuguese language option. As always, tonight we're going to be joined by Dr. Maryam Zamani, one of our fellow Next Generation editors from Orange County, California, who's going to be our discussion curator. So if you have any questions, make sure that you look at the chat box, post your questions, answer anything that comes up, either in English or Portuguese, and make sure that you respond to any of the poll questions as they pop up. We're very fortunate tonight to be joined by two of the authors from this month's article, Dr. Suma Yalamanchili from Chevy Chase, Maryland, and Dr. Andre Auersvald from Curitiba, Brazil. I'd like to thank you both for taking the time to join us here tonight to share your experience and expertise on this interesting topic with the rest of our ASJ listeners, because for any of you that's been at any meeting recently or reading through the recent issues of ASJ, you've no doubt heard lots of talk about the wonders of TXA. It's made it seem like a miraculous wonder drug that can do no wrong. But tonight we're going to be talking about a potentially darker side of tranexamic acid and question whether we need to adjust our mindset about the utility and usage of this medication. So without any further ado, I will go ahead and hand the screen over to Dr. Yalamanchili for her review of this month's featured article.
Was mixed in with the local anesthetic. And for two of the patients, it was less than 10 mg per ml dose. And I want to make a comment that all areas of necrosis was where there was a thin skin flap, which I think sets it apart from some of the literature in the plastic surgery journals that talk about maybe its use in abdominoplasty or liposuction or breast reductions. I think this is just a different subset. So these are photos from the paper. So you can see in this first patient here on the top left, she had had her skin completely undermined and released from the underlying platysma. And this is her 3 days after surgery. And then this patient on the right, this is her preauricular skin. That was noticed first day after surgery. This patient on the bottom left, this is the submental area. And then this patient on the right is again preauricular area. So again, all areas where it's a thin skin flap, not necessarily more anteriorly where you have a composite flap. There's some literature about complications with TXA, mostly out of the orthopedic literature, because they have been using it in joints. And the concern there was whether it was toxic to the chondrocytes. And some of the basic science literature found that it had changes in the cellular morphology as well as cellular adhesion. And they found that even at concentrations of 5 mg per ml, cellular adhesion was affected. And then there's a paper that looked at human keratinocytes, so human skin cells, and they basically echo the same orthopedic literature, that it affects the adhesion to the basement membrane, but the detached cells were initially still viable. So not necessarily toxic, but perhaps affecting another mechanism thought to be the integrin interaction. And they tried to identify a safe dose of TXA, and they thought that 25 mg per ml didn't cause any adverse events. But as I mentioned, our first patient, her dose was 25 mg per ml topically, and obviously she had a catastrophic result. And so I think the bigger take home is that we don't know what the safe dose is, and I think we need to be cautious when using it, especially in patients who have a thin skin flap. So whether that's a facelift patient or I think there was a recent article about using it in mastectomy patients, which again, I would caution that that might not be a great thing.
Fantastic. Thank you so much. Dr. Auersvald, you presented one of these cases was yours, unfortunately, and so thank you for sharing it with us. But I'd love to hear your thoughts as somebody who's been doing a lot of facelifts and has a lot of experience and exposure. What's your take about TXA and where we stand currently?
We were introduced to the TXA in chat groups. We have chat groups that discuss facelifts, and we start to hear good things about, TXA that reduces bleeding, and the amount of swelling and postoperative hematoma would be less than the usual traditional solution that we used before, just with epinephrine. And we introduced this medication to our practice for 3 years. But the thing is that in these last 3 years, we start to notice a huge increase in number of ischemias and necrosis. And the single modification that we did in this last 3 years was the introduction of this medication. And then we decided to quit it. It took a long time to realize that this medication could be the cause of these problems, ischemic sloughs and ischemias that we were having. And that was really very bothersome for a person that is dealing with facelifts to have a necrosis. Everybody that has experienced necrosis know that it's not easy to deal with. And if you have a large number of necrosis, you really have to be careful. And we didn't realize, because it was just a medication that was part of our routine. And we were thinking of other conditions that could have been interfering in the blood circulation of our flaps, but we didn't make any different things for the last 30 years. We have been operating facelifts for more than 30 years. In this last 3 years, we had a tremendous increase in blood compromise of the skin flap. So we decided to remove this medication, since we remember that we were putting, as this is part of our routine, we're not really remembering that we were putting this medication. Just my nurse, she was adding the medication as I told her 3 years ago. And since we quit it, our level of ischemias and ischemic sloughs returned to the baseline that we had before. It's around 1%, which is acceptable for every surgeon. So that's my, it's a brief summary of what happened to our practice. And then Talei, he invited me, told me, Andrea, you told me about this, and he told me about there are other colleagues that are experiencing the same problem. Let's put this together, and maybe just as a warning, for those that may have going to the same problem that we experienced in this last 3 years. So I accept his invitation. Thanks Suma that she contacted me, and so I'm happy to be here with you to share our experience. Okay.
That's great. I think that one of the great things about this article and reading it, why it got me really excited, is it's so easy in these situations to say, oh, this is anecdotal, one case here, one case there. But certainly as a group of experts who have come together to identify a problem that they've seen, it's nice to see this a larger group consensus trying to bring this up and sound the alarm to say maybe we need to pump the brakes. So Dr. Yalamanchili, having been through the literature and gone through everything on this, is this a dose issue? Do you think it's a concentration issue? Is it a topical versus systemic issue? Where do you think that we're coming from in terms of the science? Why are we seeing this here in these thin skin flaps, particularly in facelift and neck lift patients? What do you think is going on? So what could we adjust to try and avoid this?
It's a great question. I think it definitely seems like the thin skin flaps that don't have more soft tissue around them, more support, are at most at risk, because one of the orthopedic articles talks about the cartilage being not as susceptible because there's glycosaminoglycans and all these other supporting elements there. And so I think that's why you're seeing it just at the preauricular, postauricular, and the neck, because, you know, sometimes you're just on dermis, and so there's not anything else to provide support. As far as administration, we switched to IV dosing and we didn't have any issues. And as far as I know, none of the other authors had issues as well. And so I would say if you still want to give TXA, giving it IV seems to be a safe mechanism. And I think part of that is the dosing. So I mentioned earlier, the effective dose is 5 to 10 micrograms per ml, which is significantly different than putting 25 milligrams per ml topically, or even 8 milligrams per ml through your local anesthetic. And so I think part of it is a dosing, but the issue is I don't know what the correct dose is. And so even if you put it down to 2 milligrams per ml, is that safe? I don't know. I don't think I would want to take that risk. And so I think if you still want to use it, IV should be safe for now.
And I just saw Dr. Andrew Frankel, who's the senior author on this month's paper as well, just logged in. Dr. Frankel, I don't know if you're set up to provide any commentary or your thoughts on your experience with these unfortunate cases in facelift surgery.
Yes, hi, thank you. So Suma was my fellow last year when this event occurred, and similar to Dr. Auersvald, it was an extremely rare occasion to see this strange, what looked like ischemia in the neck, in an area that I almost have never seen it in 30 years. And it was Suma who brought it to my attention that, hey, you know, do you think it could be the TXA? And with the communication going on the chat that Dr. Auersvald mentioned with Dr. Talei, it had been a note. We knew about this within a small group of people. So then when we reached out, we found that, in fact, quite a few of us who are busy facelifters were having this, had this experience. What really struck me is when Suma dug into the research and found that there's a mechanism that I had not considered, which is that the TXA can be cytotoxic. It's not, we were thinking it in terms of thromboembolic phenomena, hypercoagulability causing microclots and what have you. But in fact, it seems like this cytotoxicity that actually, Suma, correct me if I'm wrong, it actually interferes with cell-to-cell adhesions, makes more sense. And so what we were looking at was not related to the hypercoagulability issue. It was related more to cytotoxicity. And I just think that, so anecdotally, since we wrote this paper, and in the last 3 months, 2 of my colleagues who operate at our facility have come up to me unbeknownst, they don't know about this paper. And they both told me about this weird thing they've seen recently on their patient. And it's exactly like the cases you're seeing presented here, which is the whole point. I think that the great majority of the surgeons are still unaware that there's any risk like this. The idea was to sound the alarm, like you mentioned, and just share it, whether it's anecdotal or not. It's something to give thought to it. If you insist on using it topically, I would say the length of time that your lap or your gauze that's soaked in the TXA is sitting in the field should be minimized. I really would suggest refraining from mixing the TXA with your local injection. But yeah, I think that the overwhelming experience of the people on the paper who've done thousands of facelifts is that this was exceedingly a strange presentation, and there was something else at work here. And my hat goes off to Dr. Yalamanchili, because this was 100% her identifying the problem and her taking the bull by the horns and then doing all the legwork to get this paper to happen.
Fantastic. And I'd be interested to know, as you know, Dr. Yalamanchili already mentioned, so you're still using IV TXA, just so that all of our listeners understand. You're using IV, but you're no longer using it topically. You're no longer using it in your infiltration or injection solution. Is that correct?
Correct. What's interesting is my initial reasoning for using it topically was to avoid the potential of systemic coagulopathy. You know, we didn't want to have PEs and any increased risk of that. So, and a lot of the patients are female and on hormone replacement, and it just felt like it would be potentially, at least on paper, safer to use it topically than to use it systemically. And in fact, after this happened, I've gone to using it in the general IV administered by the anesthesiologist, and we have had no issues whatsoever. And I do believe it helps. It's difficult to quantify, you know, how much benefit the systemic TXA is actually helping, but I've gone to using it routinely now. It makes me feel better for no other reason.
And Dr. Auersvald, listening to you, it sounds more so like you have abandoned TXA completely. Is that correct? Or are you still using it in the IV in your facelift patients?
No, we completely abandoned the TXA since we start, you know, to notice this increase, and we realized that this could be related to the TXA. We cannot point exactly TXA was the cause of all these ischemias, but we know that since we stopped using this, it returned to the baseline. So we're happy, you know, that now we're more comfortable with doing our facelift without risk of like Dr. Franco just said, you know, it's really it's a problem once you're not safe about medication. We quit it, and now we're back to the baseline. We have just probably 1% or less of ischemia rate in our patients. So that's much better than having 5%. We reach up to 5%. We have 17 cases in 3 years. So I have operated almost 4,000 facelifts in my life. And so it's when you get to a large number like this, it really makes you think about what's going on. And it's difficult to spot what is the reason, because you have a tremendous number of patients that you were in the normal parameters of complications, and suddenly you start to have a high risk of problem, higher number of complications, which are terrible complications. And necrosis, ischemia is very difficult to deal with, depending on the patient, depending on the location. And you know that who has had this type of problem know how difficult it is to deal with. So that's the reason we abandoned the TXA. And well, I'm waiting for new informations. And as Suma said, well, it's a thin flap. You know, we're not talking about orthopedic surgery, gynecological surgery, brain surgery. Those surgeries don't deal with thin flaps. I do this just facelifts. My practice, I just practice doing facelifts. So it's another situation. Maybe we should consider this medication a study, a more appropriate study on the effects of this medication on thin flaps. I don't know how to do that, but I will wait for that. If it's proven right, I'll get back to TXA, all right? My brother want to make a comment.
You see, when we started using TXA, we were concerned about intraoperative bleeding, because hematomas were controlled by us through the hemostatic net. So by the time we started using the TXA, hematomas were not an issue for us. We were just bothered by intraoperative bleeding, and we wanted to control even more than we had. We had control of that, but we wanted to push even further and get a better control of intraoperative bleeding. So that's why we introduced TXA. So going back for us was not such a big deal in terms of postoperative hematomas. We keep not having them because of the hemostatic net.
And another point, I think that there's a difference. A period of time, I did facelifts with subcutaneous detachment and plication. The larger I think in my perception, this is just an observation that the wider the detachment, the skin detachment, the higher the risk of tranexamic acid interfering in the blood circulation. What is interesting is that the type of ischemia that you observe with this medication is different from the traditional ischemia that you see in regular facelifts. I don't know if Franco agree with me, because it's different pattern, like flocculated in small patchy areas, is not in the tip of the traction, you know. It's a sort of different pattern of ischemia and necrosis.
Yeah, you know, it's interesting. So you mentioned the hemostatic net. Are there specific procedural technique variables? So you say, you know, large skin flap, glycation, the use of the net. Do you think that influences the impact of TXA if you're, let's say, not using the net? Let's say you're using, you know, a less undermined area, smaller flaps. Do you think that it would have the same effect, or could you potentially get away with it? So are there technique variables? And then the other back part of that is, are there patient variables, revision cases? Are there really thin patients? Are there patients who are probably more prone to these issues? I'd love to hear the group's thoughts from the three of you.
Well, we in our study, these 17 patients, I went back to all these cases. 95% of them were primary case, so it's not secondary. This calls attention for this point. Most of our patients were primary facelifts. So, I cannot tell you the thickness of the flap. If they were thin skin or thick skin, I cannot tell you. But 30% of our patients were wider skin detachments, and the other part were deep plane, you know. So I don't see much difference, but I remember that when we were doing a wider skin detachment, there were maybe a slight difference in terms of ischemia. You mentioned the hemostatic net. We've been using the hemostatic net for over 15 years, so many years. And just in the last 3 years, we started to have problems. We were using the hemostatic at the tranexamic acid to try to reduce the transoperative bleeding, because we have had no issues in the postoperative recovery because of the hemostatic net. It has dropped it to zero, our rate of hematomas and fluid accumulation. And the rate of ischemia that we have the hemostatic nets is the same as we have before the use of the hemostatic net. It has been proven. There are many papers that we have seen already published on the safety of this technique. But, you know, we were trying to improve, even go, as my brother said, further, trying to reduce the transoperative bleeding. But, you know, we didn't find difference. And I think the two of the papers, the most important papers published in the literature, didn't find difference between, you know, transoperative bleeding, and some other found a huge difference. Well, in my experience, it didn't make a lot of difference, but I respect for those that think that you can reduce the time of your surgery. Good, that's great. If you don't have no problems and issue with your skin flap, that's okay. So I think maybe you can continue using this medication. But just a warning for those that may have been experienced skin slaps, ischemias, and are not understanding the reason for that. I've been doing these facelifts for so long time and never had such problems, and suddenly start to appear different complications that I didn't have before. So maybe you could think about this medication, try to quit it and see if it gets back to normal. In our case, this happened. You know, we were going well until starting using the tranexamic acid, and then we discontinued the medication and things went back to normal. And I'm happy now because I can operate without this problem that we experienced for this last 3 years, 2021, 2021, and 22nd.
Yeah. Dr. Yalamanchili, Dr. Frankel, we see a question and comment in the chat box as well. I'd love to get your thoughts about this. Patients with previous radiofrequency treatments, energy application to the neck, other treatments in those areas. Do you think that influences it? Do those need to put us on high alert, or is this drug just putting us on high alert at baseline?
I think that I don't believe those. This conjecture, I have no idea. So since this is a scientific meeting, I would say I don't know. However, it seemed, so I'm a deep plane lifter for 29 years, and I don't know of any of these. All of us were using deep techniques, and everyone's area of ischemia or necrosis problems was all in the skin portion, the non-composite portion. And as Dr. Yalamanchili pointed out, it seems to be that the dermis is susceptible, and whether prior treatments with laser or radiofrequency would make it less susceptible or more susceptible, I don't know. I think the point of the entire paper is that we've noticed something that's a deviation from what we've all experienced for many, many years. And we have 4 different practices, and this is a common denominator. And now that we've mentioned it, people are coming out of the woodwork saying, hey, I've seen this before too when I've used TXA in my local. And so I think it is worthwhile to give this consideration and measure the potential value of using TXA topically or in the local versus the potential disaster of a big time, skin flap issue, which none of us want to have. In terms of responding to the injury, we sent my patient a hyperbaric, and she ultimately healed up well, but she was hyperpigmented for months, and it was a kind of a very difficult period for her and for me to get through, as you can imagine. It reminded me of when my patients used to smoke a great deal. That's kind of the look of it. And that's why we consider it to be ischemia. But whether or not it's truly ischemia due to microemboli or to cytotoxicity, I don't know. But I think if you have a thick flap, that you're probably much safer using this in the local solution or topically.
The other thing that's interesting is, Dr. Auersvald said that most of his patients were primary, but the patient of Dr. Frankel's was a revision. And you would expect that she would have more robust blood flow because a revision patient, the delay phenomenon. And she didn't, she was the one who had issues. And I had another surgeon email me. She had a similar issue, I think a preauricular area in a revision patient. And so that doesn't necessarily make a lot of sense either, because those skin flaps should have better blood supply. And so that's another reason why we think there's a different mechanism.
And Dr. Singer, I know that you had a question that you wanted to ask, so please take the floor and pose anything to our experts here tonight. Oh, we have you muted there, Dr. Singer. We'll just get you to unmute yourself.
Hi.
Perfect.
More a couple comments. I've also done thousands of facelifts, and I don't do a deep plane. I do a bilamellar, elevating the SMAS and the skins separately. So my skin flaps are probably thinner than what you've mentioned. And I use this and have been using it for years in my local, one ampule and about 250 cc's, and I inject it with that. I don't use it on my topical 4x4s or gauze specifically. I use it, and not only there, I've used it and rhinoplasties and blepharoplasties, thin skin. I've not seen the problem. I appreciate you're bringing this to our attention, and it's always difficult to show problems of your own. So my compliments to all of you for doing that. I think some of the questions that I had were somebody else addressed. Had any of these people had a radiation? Had they had other therapies of their neck with laser lipo, with radio frequency? Do any of them have any collagen disorders of things like Raynaud's? And also, I'm concerned how much of this, the concentration that was directly on the sponges, and could they have been in higher concentration directly under those areas for a longer period of time? Also, is there anything that's changed with your dressings and who puts on your dressings? Maybe there was an undue amount of pressure in those areas of bunching up of the bandages. I don't know the answers, but this certainly stimulates our thought process. And one of the things we did with ASERF is to ask them to commission a study multi-center to determine what is the best method of delivering Tranexamic, since it's essentially in the hands of each individual is a little different, and we don't have the answers for that. So this stimulates a lot of questions, but I appreciate you bringing this to our attention. I also see Jim Furneaux's on this group, and Jim has published and has had extensive experience with Tranexamic, and I'd love to hear his comments.
We'll see. Dr. Furneaux, are you there and available to make a comment?
Can you hear me?
Of course, that's great.
Yes. So I too have used TXA in many liposuction cases. I've never had a complication like that, those unfortunate cases, and I applaud the authors for showing those cases. I mean, that's very honest and very forthcoming. And I don't know that we really know the answers. I think Dr. Singer brings up some great points. I have had some complications in, of course, distal facelift flaps in the preauricular area, but they're pretty routine. I can't say that I can attribute it to TXA. I can't really say that I can attribute any of the complications to TXA. And I do use it intravenously. I use it topically, and I inject it as well. I use it topically as a 3% solution. I inject it as a 1% solution. However, after seeing some of these cases, it is definitely going to make me think about injecting the local anesthetic at maybe a lower concentration. And I really do appreciate everybody. It's an excellent work, and excellent commentary on the paper too. Thank you, Dr. Singer. I appreciate it.
And one thing I'd like to know from our experts tonight. So do you think that, when we're thinking about this topical application or potentially injecting it, do you think that combining this with epinephrine has a kind of double hit role or phenomenon that could be further, causing local tissue ischemia and then allowing that injury from the TXA to propagate and get worse? Or is it just the TXA in your mind?
Well, yeah, we use 1 to 500,000 dilution of the epinephrine, so it's a very let's see,
Very diluted.
a very
Very
diluted
diluted, yeah.
solution. So I would say that this concentration wouldn't contribute to a higher risk of ischemia. I don't know if you agree with me, but 1 to 500,000 is not a very concentrated solution. So I wouldn't blame epinephrine. Maybe the combination of the two of them is good. I know that Dr. Zim is trying to separate the injection of epinephrine and tranexamic acid. That could be a good idea. That trying separate them and study the two medications separately. But I think it didn't come out yet with this final study. And well, if you look at the literature, you're going to see that there are some interesting papers, and there are just 3 eligible papers on tranexamic acid. You know, we have 2,400 papers published on tranexamic acid. Most of them are not in facial plastic surgery. Just 3 are eligible for facelift. So this calls the attention. Maybe we need further investigations to to check if the safety of this medication. I know that there are groups like Dr. Sin is studying very deeply this issue, and I'm glad he's doing this. So far, at this moment, I have to to keep my experience and to see my experience and continues, still waiting for new information for the safety of this medication in facelifts, not in general surgery, not in trauma, not in orthopedic, not in body contouring, not in breast surgery. I don't know. I don't do breast and body contouring, but I would wait for new informations on facelifts. We just have 3 papers on facelifts, that can be really that attend the expectation of a scientific paper, and other papers that have been published but they don't meet the criteria. Okay, so that's a good point. Just to start with, we need more publication, more research, and deep research with control groups and double blind, and that would be better for us to understand these problems and really understand if what I had and Ben Talei had and Dr. Franco and others, so many others colleagues, they're sharing their experience with us had. So if this is really related to TXA or not, at this moment, I'm putting on hold.
I think the one, I don't know about the epinephrine, but I do think that it is a time dependent. So topically, if you're limiting 10 minutes versus when you mix it into your local anesthetic and you're injecting it, that sticks around for a lot longer. And so that's a prolonged exposure. And I do think that plays a role because Dr. Frankel's patient had superficial epidermolysis, but she didn't have any full thickness necrosis. She healed on her own. She didn't necessarily have any complete loss of tissue, but I know Dr. Talei's patient, he had to do some skin replacement surgery. And then Dr. Auersvald, I think you had to do full thickness excision of some of the skin in your patient. And so both of them had injected into the local anesthetic. And so I do think prolonged exposure is something to consider, even though they had smaller concentrations of TXA than Dr. Frankel's patient, but their patients probably had longer exposure to it. So that played a big role.
It's so interesting when we look at the results from the polls tonight. Most of the respondents tonight are using TXA and they're using it routinely. Most of them are giving it intravenously, but many are using it topically, and a lot are using a combination, as we've heard. So giving it IV and then using it either in the infiltration solution, the injection, or topically as well. But what I find interesting is that when we see, has anybody had any complications with this? 21% of the respondents have experienced tissue ischemia or wound healing issues. And so I think that one of the fantastic things about this article and bringing this up and for our, authors for, having the courage to present these awful complications and put them out there for the world is that we're actually seeing that a lot more people are noticing issues with this. And when we look in the chat box as well, there's comments about some episodes of nipple-areolar complex loss in breast reduction surgery in patients who are using TXA as well. And so I think that the more that we talk about this, the more that we bring it up, the more that we think about it and actually think to look and question why these things are happening, as you all have done, to say, why are we experiencing this new phenomenon, will shed a lot more light on this medication and hopefully give us more answers, spawn more scientific studies. Because 52% of or over 50% of the attendees tonight said that they're going to plan to change the way that they use or think about TXA, whether that's concentration, route of administration, patient selection. And, I think it's fantastic. This journal club has raised almost more questions than it's provided answers. But I think that that's one of the fantastic things about this journal club and this forum and ASJ in general, is that we all get together. We're trying to get the best results for our patients and move our entire specialty forward. And it's through research like this that brings up a question even without an answer, just so that we can have the discussion, so that maybe we can take this on to the next level. We're getting close to the end of the night, and I know for Dr. Auersvald and for our attendees from Brazil, it's getting late into the night, and so I thank them, and I want to be respectful of time. For Dr. Yalamanchili, Dr. Auersvald, any last comments before we tune out for tonight?
Let's say something. Well, I'm glad to be invited here to discuss this issue. I never thought we would get to such a nice debate like you're running here, Dr. Ryan. Thank you so much for being with you and share our experience. Of course, there are different point of views. I know that many surgeons are having good experience with TXA, but we are sharing our experience too, which has changed a little bit in the last 3 years, and now we are okay. So thanks for inviting us to be with you here, and thank to the American Society for bringing this issue to the to shed light on this issue. Thanks a lot.
Yeah, I'm just grateful.
Dr. Yalamanchili?
Just grateful that, this could help some other people. It was great for me to have the experience where I worked with a lot of other people, so I could see that other surgeons were having these issues. But, I felt like everyone else needs to know, and I shouldn't be the only person fortunate enough to hear it just because I had that, opportunity and fellowship. And so if I can help other surgeons prevent some of these complications, that'll be great.
Precisely. I think there was a comment in the chat box saying that I haven't experienced this yet, and it's fine to have that until you do, and then it's a disaster. And so if we can help to prevent this in some way, whatever that's going to be, and try and help our patients and get the best results we can, I think that that's all that we can ask. So we're getting towards the top of the hour. I would like to thank Dr. Yalamanchili, Dr. Auersvald, and Dr. Frankel for jumping on as well, Dr. Furnow for your insights, and Dr. Singer as well. So thank you all for tuning in, and special thank you to Dr. Diego Pereira, who provided our expert translation to Portuguese tonight. So thank you all. We're excited to have more involvement with the Brazilian Society, and look forward to many future endeavors together. So all the best, everybody. Stay safe and healthy, and we look forward to joining you online for our next journal club with the YAPs in a few months. Stay safe and healthy, everybody.
Thanks, everyone.
Great job. Great job.
Obrigado, Diego. Obrigado, Diego.
Great job.
You so much.
Obrigado.
Merry Christmas.
Obrigado. Thanks. Bye-bye.